Hi, my name is Vera Davis. I'm a graduate nursing student at West Texas A&M University. Today I will be performing a head-to-toe assessment on a 48-year-old male patient who's come in for a physical exam. I have already completed general survey and review of systems and have reviewed his past medical history, social, surgical, family, and allergies and immunizations. He has no allergies. I've also reviewed his medications with him. I've already completed his vital signs, his height and weight, and calculated his BMI. I've also evaluated the cranial nerve number 2, the optic nerve with the Snellen E chart, and his vision is 20/20. I've already washed my hands, and we are ready to begin our assessment. And throughout the assessment, I will evaluate the patient's skin for any lesions or nevi, moles, or any discolorations or abnormalities. Begin by evaluating the patient's head, and for symmetry of the eyes and the ears are symmetrical. His nose is midline, as well as his mouth is midline. And I will palpate his skull. His hair is the characters is evenly distributed. I feel no lumps or bumps in his skull. And I will go ahead and complete cranial nerve number 5, the trigeminal nerve. And close your eyes and just let me know if you feel sharp or dull.
Dull. Sharp. Sharp. Dull. Dull. Sharp. Dull. Sharp. Sharp.
Oh, sorry. And I will also take a look at this patient's eyes and looking at the conjunctiva of his eyes. I'm going to take a look, which are pink, and his sclera is white. And I will evaluate for cranial nerves number 3, 4, and 6, ocular motor, trochlear, and abducens. Ocular motor, I will evaluate consensual and his eye responses to direct and consensual light and accommodation. Direct, consensual, direct, and consensual. I will evaluate for accommodation. If you would please look at this at my pen light in the back of the wall. Pen light in the back of the wall. Very good. Eyes accommodate well. I will complete the 6 fields of gaze, which is the trochlear evaluation, the trochlear nerve evaluation for this patient. If you would please just look with your eyes and don't move your head. Follow the pen light. Very good. And now I will evaluate the abducens for this patient, noted with the ophthalmoscope, and I'll evaluate the patient's eyes for pupillary response, size, as well as evaluating his optic disc and looking for the red reflex and noting if there's any papilledema, and noting the borders of the optic disc. They should be smooth and sharp. And just kind of look past my light there, please. The red reflex is present for this patient. I see no papilledema, and the optic disc is, the edges are smooth and sharp. Continuing evaluation of this patient, I will take a look in and feel the auricles of his ears. There's no bumps or lesions. I'll take a look at the internal ears of this patient, noting any noting his tympanic membrane, evaluating that it is intact, noting any discoloration of the tympanic membrane, any swelling, any redness, any fluid buildup, as well as noting for the cone of light in each ear. For adult patients, I will lift up and out. And the cone of light is present. His tympanic membrane, there's no swelling, redness, accumulation of fluid, and the eardrum is intact. There's no perforation. As well as the same for the left ear, and cone of light was present in both ears. Moving on, I will continue cranial nerve number 7, completing the whisper test for this patient. If you would please cover your opposite ear and just tell me what you hear.
55.
Very good. And the next ear.
66.
Very good. And I'm also going to complete the Weber test, which tests for the hearing, the symmetrical hearing for this patient. If you would please just tell me if you hear this, hear the vibration or the sound bilaterally.
Yes, I hear it.
Both ears?
Yeah, more than that.
Okay, very good. He has advised that he has a little trouble hearing on his right ear. And next we will do the Rhine test, which tests the air to bone conduction, and the normal is 2 to 1. So I'm going to strike my instrument and place it behind your ear. And if you would tell me when you stop feeling the vibration, and then I will remove it, and then you tell me when you stop hearing, okay? Alrighty, very good. Okay, moving on. I will evaluate the patient's nose, and just looking there, I see no signals of deviated septum of this patient. His nose, like I said, is midline. I'm going to evaluate inside his nares. First, we're going to do, if you would please, when you occlude one nose and just take a sniff. All right, and the next. And now close your eyes, occlude one nose, sniff. Again, the other. And what do you smell?
Peppermint.
Yeah, okay. I'm gonna take a look inside. Can you raise your nose for me? And I see no swelling of his nasal passages or any exudate, no polyps seen either. I'm going to take a look in this patient's mouth, and his lips are normal color for his complexion. There's no sores or blisters on the outside of the lips. If you open your mouth for me, please, sir. So I'm going to take a look inside. Looking at his mouth, I see no sores or white patches. Can you lift your tongue? Very good. No sores under the tongue, indicating any type of infection or cancerous lesions. And next I will complete additional cranial nerves of this patient, the glossopharyngeal for the gag reflex. And so if you would open wide for me. I'm sorry. Open wide. Alrighty. Gag reflex is positive. Also, we'll do the vagal nerve. If you would say ah for me, please.
Ah.
uvula is present in midline. And next we'll do the hypoglossal, which is the, if you would stick out your tongue for me, please. Stick it out straight, go side to side, straight again. And tongue is nice and straight in midline, so that is good. And so I will continue, and that was cranial nerve number 12, the hypoglossal. And I will complete with, that was cranial nerve, yes, cranial nerve number 12. And now we'll do cranial nerve number 11 to complete the cranial nerves, the spinal accessory. So if you would please lift your shoulders and just kind of go against me, lift up. There you go. All right. Also check the strength of his shoulders and if they are present. Moving on. Looking at this patient, we'll go down to his neck. The patient's neck there's no visible masses. I see the trachea is nice and midline. I'll evaluate his thyroid. If you would please swallow. Alrighty. And the patient's thyroid moves with his swallowing. I didn't feel any masses or any swelling in his thyroid area. Now I will complete his an assessment of this patient's lymph nodes, noting for the size and shape of the lymph nodes, noting if there's any swelling or tenderness to his lymph nodes. And we'll start with pre-auricle, post-auricle, tonsillar, submandibular, submental, cervical, post-cervical, and sternal supraclavicular. And also we'll evaluate his axillary, and those are very good. Don't feel any swelling or tenderness of his lymph nodes. Moving forward, we will now have the patient turn to the side, and I'm going to evaluate his, do an inspection of, may I lift your shirt, please? Alrighty. Evaluate his, the posterior thorax, and I don't see any accessory muscles for his breathing. He does have a little sebaceous cyst to his back area here. No dyspnea noted. For this patient, I'm going to go ahead and palpate for fremitus for this patient. So if you would please just say 99. Very good. And now I am going to percuss the patient's back and listening for any his lung zone, any hyperresonance or dullness. Hyperresonance would indicate any kind of lung disease, COPD or asthma. Dullness would indicate fluid-filled lungs, pneumonia. Going in a ladder-like motion. And now I will palpate the patient's back for diaphragmatic excursion, and noting the sounds where resonance ends and dullness begins. And so if you would please, sir, take a deep breath in and hold it. Alrighty, and let it out. And we'll do some measuring. And then again, what I'm gonna have you do is take a deep breath in, let it out, and hold it. So deep breath in, let it out, and hold it. Alrighty, so that measurement's right about 3 to 4 centimeters. And now I will continue with auscultation of this patient's lungs, checking the lungs in all fields. Just deep breathe in and out. lateral. I will now evaluate the patient for bronchophony, egophony, and whisper pectococcyly. If you would, please say 99.
99. 99. 99. 99.
Now say E. Alrighty, very good. Now we'll go ahead and flip them. Oh, actually, I'm going to evaluate for coastal vertebral tenderness for this patient, and just checking for any inflammation in the kidneys. Alrighty. Now we'll go ahead and turn around to the front and continue our exam of the posterior chest of this patient, noting that there's his chest is symmetrical. There's no concave or no concave or barrel chest, indicating any kind of hyperinflation of his chest or any underinflation of his chest. His breath, his breathing is arrested. He's not labored breathing, no dyspnea notice. I will evaluate, fill his chest or his chest area for any heaves that might be present. Just breathe normal. Lifting of my hand abnormally. And now I will fill this patient over in the mid-clavicular line for the point of maximal impulse, which is present. And I will complete percussion of the anterior thorax. In this patient, again, looking for any hyperresonant or dull sounds of his lungs. Alrighty, and now we'll take a listen to the anterior lung sounds. Just breathe normally for me, in and out. While I'm here, I'm going to go ahead and take a moment to evaluate his temporal pulses and his carotid pulses. 2+ and positive. And I evaluate the carotid on each side individually. No thrills heard. And also will evaluate the carotid with my stethoscope. If you would take a deep breath in and hold it. No bruise or whooshing noises heard. You can let it out, I'm sorry. Take a deep breath in and hold it. All right. And we'll go ahead and complete a percussion, and I will listen to your heart sounds, listening for the S1 and S2. The location that I will listen to is the right side, second intercostal space. The sternal border is the aortic. The left side at the second intercostal space, at the sternal border, is the pulmonic. The left side at the fourth intercostal space is the tricuspid, and the left side, right at the on the left side at the fifth intercostal space, is the mitral or the apex. And I I will listen with the bell of this stethoscope. Listening for any murmurs that might be heard. I'll begin at the base and work my way down to the apex. No murmurs heard. Alrighty. And I'll go ahead and assist the patient to lay back. I'm going to have him lay back at a 30-degree angle, and we'll go ahead and evaluate for jugular venous pressure. I'll have my centimeter ruler, and I'm going to place the ruler at the angle of the sternal border to the, and turn your head left for me, please, sir. And looking at the highest point of that meniscus. And this patient measures right at 4 centimeters, a little bit under 4 centimeters, and that is normal. 3 to 4 would be normal. And while he's lying down here, I'm going to go ahead and evaluate his abdomen. And during expansion, his belly is round. I see no obvious pulsations of his abdominal aorta artery, and his umbilicus is inverted, and no lesions or masses noted. I will actually auscultate the patient's bowel sounds in all 4 areas, listening for tympany, that is expected sound, and listening for the hyperactive or normal active bowel sounds. Patient's bowel sounds are positive, and normal range is between 18 to 34 in a minute time frame. I will now percuss the patient's abdomen, listening again for sounds of tympany in his abdomen. And I will do a light, actually I'm going to percuss for the span of his liver, and I will start at the level of his nipple and work my way down until I hear dullness, and then I'll come over from the umbilicus and work my way up until I hear dullness, which will estimate his liver span. There, dullness begins right there. Right here. And this patient's liver measures right at 8 centimeters, which is normal. Now I'll perform light palpation of the patient's abdomen and just assessing for any masses or any tenderness that the patient might experience while I do this. Now I'll perform deep palpation to evaluate the patient's liver to see if I can feel his liver. I will place my left hand underneath his back, and I will perform deep palpation with my right hand. The liver is felt, no enlargement felt in the patient, had no tenderness. I'll place my left hand underneath the patient's left side, and we'll evaluate for his spleen. And I cannot feel his spleen, and that is normal. I will evaluate the patient's abdominal aorta and just listening for any thrills or listening for any bruise. No whooshing noises heard, excuse me. And also we'll evaluate the iliac arteries. And the femoral. No bruise heard. Alrighty, moving on down. Thank you, sir. Moving on down, I'm going to evaluate for any kind of herniated disc. I'll do inversion, dorsiflexion of his foot and raise his leg. Alrighty, and while I'm here, we're going to go ahead and do range of motion of the hip. We'll do flexion, extension, abduction, and adduction, internal rotation, and external rotation. Left side, flexion, extension, abduction, adduction, internal rotation, and external rotation. And I'm going to have you sit up so I can do your knees. And if you just hop down real quick and squat for me. And flexion and extension. Okay, come back up. So to the end. Thank you, sir. I'm going to go ahead and continue, begin again at his shoulders. And then we'll do abduction of the shoulders. Get your arms out. And adduction. And external rotation. And extension. Very good. And now we'll look at his wrists, and we'll do, if you would pronate, put your hands down. Plantar flexion, dorsiflexion, abduction, abduction, and adduction. We're gonna go, okay. Plantar flexion, plantar, dorsi, ab, and ad. Very good. Going to do a little cerebellar testing of the hands with pronation and supination. If you just flip flop your hands quickly on your thighs. Very good. And now I will evaluate his range of motion of his of the elbow, which is and do me a favor and just don't let me pull you. Don't let me prevent you. All right. Very good. So abduction. No, flexion and extension. Alrighty. And flexion and extension, the same thing. Very good. And we will, let's test the strength of your hands. And just squeeze for me. Very good. And now I will, if you would pronate your ankles. Flexion and extension. Very good. Okay, and now moving on, we will do your pulses. And I'm going to evaluate his brachial pulses, radial pulses, popliteal pulses, posterior tibialis, and dorsal pedis. We'll continue on with reflexes, and we'll do the triceps reflex. And just relax your arm for me, please. Very good. And now the brachioradial reflexes. and his knees. And Achilles. Okay, we're going to come back and do a little number recognition and object recognition. And now, will you please close your eyes, and I'm going to trace a number in your hand and tell me what it is.
8.
Okay, I'm going to place an object in your hand, and you tell me what that object is. Stenosis.
2.
Thank you. Very good. And we will also do a little point to point. If you would just place your hands out here, and I'm going to point, if you close your eyes, I'm going to point to one of your fingers and touch your nose with the finger. Very good. And you can open your eyes and look at me, and we'll do point to point. If you would please run your heel of your foot over your shin. Very good. Now do that with the other side. Very good. I'm going to do a little proprioception. If you would tell me, just look ahead and tell me what toe which way I point your toe.
Right.
Very good. And we will have the patient stand up and evaluate his balance by the Rumbar test. And if sir, if you would please just stand straight and close your eyes. We're noticing his balance, that he doesn't become unbalanced or uncoordinated. We step out a little bit and bend over for me. I'm just going to check your spine. Spine looks good. No curvature of the spine, indicating scoliosis. No kyphosis. Checking that SI joint and making sure non-tender. And just come up a little bit. That's very good. Alrighty, and stand on that. And so now I'm going to just we're going to do a little walking. If you would please just walk normally towards me. Checking the movement, okay, stop. Checking the movement of his arms and his balance. And now if you would turn around and walk backward, we'll do some tandem walking. And now turn around, tandem walking. We're going to place one foot in front of the other. There you go. And now walk heel toe. And then go back and walk on your heels. And then walk on your toes. All right, very good. And if you would have a seat, I'll continue with relaying information in regards to male and female genitalia and the examination of those. For the female patient, of course, as it knows, I would have washed my hands again to begin this examination. Make sure the patient is comfortable for both male and female. I will have an assistant in the room as well during the evaluation. For the female patient, the evaluation of her chest and breast area will be done in 3 different directions, or 3 different positions. The patient sitting, the patient laying with arms overhead, and the patient standing with arms at hips and forward moving. I will evaluate the skin color, the texture, the tone, notice any dimpling of the breast tissue, any sores, the nipples and the areola, and noticing if there's any exudate or discharge, squeezing or pressing the areola to see if the nipple area, if there's any discharge, indicating the possibility of green or yellow, meaning infection, or red, indicating cancer for that patient. I will examine the patient's breasts, both breasts, completely, and work in a vertical motion, going at a small circle movements of that patient, and working my way from the total breast, and including the axilla, the peripheral, and the tail. For the moving into her pelvic exam, I will of course wash my hands, don gloves, and use appropriate lubricating jelly for that patient. I will insert that insert the speculum, at an angle initially, and then enter in, excuse me, let me back up. Actually, we're gonna examine the external genitalia first, the labia majora, the labia minora, the vaginal area, the urethra, meatus, and clitoris. And then we'll move forward to inserting the speculum into the vagina to evaluate the cervix, inserting it at an angle initially, and then we will move into, it will go horizontally, and then I will be able to evaluate her cervix, looking at the color of the cervix, any drainage at the cervical os, as well as retrieving a specimen from the transformation zone. Of course, I will have relaxed the patient throughout the whole process. When removing the speculum, I will evaluate the patient's vagina and notice any color to that vagina. And moving forward, the patient needs to have a rectal exam. That will be done in the lithotomy position. But actually, I will do a bimanual exam of that patient as well, inserting 2 fingers into her vagina, my hand on the top of her belly. And what I'm going to be feeling for is her uterus and her the cervix to fill it, and both ovarians, or both of her ovaries. Moving forward to the male patient, I will evaluate that patient's his chest and evaluate his skin color of the chest, looking at moving my hands to his pectoral muscles and working my way down, feeling the axillary and feeling any nose, any tenderness that patient might have. I'll also look at that patient's, I'll also look at the areola and the nipples of that patient and see if there's any, palpate any drainage. For the male and female patient, doing the digital rectal exam, of course, donning gloves, using KY jelly, lubricant, letting the patient, making sure the patient's comfortable, reassuring them, asking them to deep breathe and relax, evaluating the exterior, the perianal area, the sacrococcygeal, and noticing if there's any lumps or fissures or hemorrhoids, and being cognizant of that. For the patient, I will enter my finger into the anus, feeling for any nodules, any polyps in that rectal vault, continuing on to move forward, feeling the sphincter and the texture of the sphincter. For the male patient, I will also evaluate his prostate, moving forward at a counterclockwise to evaluate that prostate gland, as well as the seminal vesicles, noting the shape and the texture and if there's any tenderness. Coming out, I will tell the patient that just to take a deep breath and relax, and of course continuing on the possibility of feeling that he might have to urinate, but pulling out my finger, I will evaluate his rectal, any stool that was on there, the color of that stool, any bleeding. And that would complete my head to toe exam. Thank you.